Welcome to medical students who join us in this series of lecture of cardiovascular disease. Our subject today title is the common cardiac arrhythmias. Really we'll discuss the fundamental, the essential, and what you should know, what the student should know about the common arrhythmias in the intensive care unit or coronary care unit or emergency department. This is the conductive system of the heart. You know the heart is composed of the myocardium, endocardium, pericardium, and the coronary circulations with the conductive or conducting systems. These conducting systems form from about less than 1% of total heart structures. So form from SA node down to the AV node, then bundle of his, then anterior and posterior fascicles, and this is left bundle branch, one is the right bundle branch with the Purkinje fibers. So the impulse starts in SA node, which is called the dominant or natural pacemaker of the heart, because it discharges spontaneously since 8 weeks of intrauterine life. And the impulse come down to the AV nodes and down to the Purkinje fibers. So impulse conductions let us to start from the SA node, natural pacemaker, sinoatrial node, which is really the dominant pacemakers, and interatrial conducting system to the atrioventricular node, from it to the infranodal structure, bundle of his, and then the fascicles, anterior and posterior, and Purkinje fibers. Depolarization start into the septums and to the left ventricle and spread to the right ventricle. So impulse originated regularly and frequency of about 60 to less than 100 beats per minute. This is normally. This is what called normal sinus rhythm. Is the rhythm start from the sinus node down normal atria down to AV node, not delayed too much, and to the bundle of his to the both ventricles. And this sinus rhythm, the rate is, if you look to it, about 90 to 95 beats per minute, and as we know that in sinus rhythm from 60 to the less than 100. Regularities. Regular, if you take R wave distant and measure it in this record, you found it nearly similar. P wave normal and normal configurations, which proceeded for QRS complex. Every QRS complex preceded by P wave. P wave, you know, atrial depolarization, and QRS complex ventricular depolarization. QRS complex look normal, small, Q wave, then R wave, then lastly in the S wave. This is on duration about 2 small square. PR interval normal. The PR from the 3 small square to the 5. It means 0.012 second to the 0.2. Oh, say in a millisecond, 120 to the 200 millisecond. So if we have a rhythm like that, this is called normal sinus rhythm. Any deviation from that normal sinus rhythm in a rate or in a configuration, abnormalities, it's not like that the normal sinus rhythm is called dysarrhythmia or cardiac arrhythmia. So normal sinus rhythm implies normal sequence of conduction originated in the sinus node, natural pacemaker of the heart, proceeding to the ventricle via AV nodes and his Purkinje system. ECG characteristic, if you look, it's regular RR interval, narrow complex less than 3 or 3 square, small square, width of the QRS complex, rate between 60 to 100. Each QRS complex, it must preceded by P wave. And P wave is upright in lead 2 and down in AVR. This is what called sinus rhythm. If we look to this about 75 rate, every QRS complex, there is P wave. If we take RR distance equal, and every P wave, as we said, normal QRS complex duration and configuration, PR interval normal, so this is a normal sinus rhythm. A few points about action potential. I know this subject, we take it in introduction of the physiology of cardiovascular disease, but better to remind you because of this important in case of studying the cardiac arrhythmias. So in action potential, now we have three main channels: sodium channel, potassium channel, and calcium channel. This is the basement membrane of myocardium, and at resting, at the resting, the more sodium and calcium outside, the more potassium inside. And to start with the preparations of the membrane to be fired, really, pre-fired, and that the voltage is a minus 80 at the resting to the 85, nearly 90. Above 80 is nearly to be fired. If fired is the phase 0. Look to the sodium channel, fast sodium channel. Why it's fast? Look at how it's fast. This fast enter more sodium inside and lead to the depolarization. And then it's followed by phase 1, which is early repolarizations. And that the potassium channel, it will be open, some potassium efflux outside, and this is early repolarization. The second phase is the cold plateau, due to the opening of the slow calcium channel, and the calcium enter inside the cell and give this phase what is called the plateau of phase 2. A few points about calcium in the myocardium, different from the calcium in the striated skeletal muscle. In the striated skeletal muscle, the sources of its only endoplasmic reticulum, while in a myocardium from extracellular onto the endoplasmic reticulum. And this plateau also not present in the striated muscle. The benefit of this phase 2 or plateau is a more time, little bit the longest phase. It is a little bit more time for the left ventricle, even right ventricle to fill with the blood. I mean, there is more time for the venous return, more time to fill the left ventricle with the left ventricular and diastolic volume. This is important to eject the blood at the proper ejection and proper cardiac output. And the third phase, more potassium will be outside. This is the rapid phase of the final phase of the repolarization. While phase 4, the net result, what the potassium outside enter, sodium will be outside. This is the influx, this is efflux outside and return back to the resting membrane. So it is total sodium out, total potassium in, and return. So it is 5 phases, and then return to the resting phase, to the next beat or next cycle. This really not happen in the SI node, because SI node there is no resting. It's fire continuously, and it's like phase 4. And the important for the important for the SI node to dominate other part of the heart. So it is, this is SI node action potential. It is only really a phase 4. This slide really to remind you that antiarrhythmic drug, when classified, every group it acts in a phase. This will be discussed in details in that when studying the antiarrhythmic drugs. What the mechanism of the arrhythmia formation? Not the etiology. About the how mechanism, there is four main mechanisms. Re-entry is the most common, or re-entry circuits or circuit. Automaticity, I mean enhancing wing tachycardia or slowing wing bradycardia, are trigger activity and parasystole mechanism. The first mechanism, re-entry, is required really the most common cause of the arrhythmia, especially tachyarrhythmia. So that if the electrical impulse is coming, there is two limbs. One limb, one way is the slow conduction, by the way. The second is the fast conduction. But the difference that the fast recovery, refractory period is short. Here is the slow recovery. Refractory period in fast conduction is the slow and take more times. Normally the impulse is passing there. And if this is the previous slides normally, if there is some premature beat, depolarize, and that the signal or that the activities is strong enough and to overcome SA nodes, and this impulse is conducted, is coming in unilateral block, unidirectional block in a fast Y block because slow recovery. And this is passes in slowly, but there is recovery is the fastly, so it can pass down. So it is passed down, some it is come into the fast conduction. At that time, the refractory period is off, so it is conducted retrogradely. And some it go to the retrograde, other it's come down, the slow conduction. And this is what called slow to fast circuits. There is fast to slow, it's rare, slow to slow, it's rare too. The commonest re-entry mechanism is the slow to fast. And this is the unidirectional block, the fast pathway, and the slow is becoming yellow, and it is do a circuit like our re-entrant. This is to the atrium bag and to the ventricle. Some it's circuits, other down to the ventricle. Look again, this is a normal. While there is an ectopic, or ectopic beats, or the ectopic focus discharging, so the slow it's passing down, and this is still in a refractory period. When it's reached the refractory period and do this is re-entrant and circuits, really the main mechanism of tachycardia, and that it's continuous like a circuits. This is what called re-entrant or the recircuit or recircuit into a mechanism to produce tachycardia. So electrical impulse, the cardiac conductive tissue, conduction tissue, the slow conduction and the fast conduction, and the unilateral, unidirectional blocking of depolarization in that direction because of the slow recovery, and the slow it down because of the fast recovery. And this is what called re-entrant or re-entrant circuits is a main cause of to form the following arrhythmias, like atrial re-entrant, which contain atrial tachycardia, atrial fibrillation, atrial flutter, atrioventricular re-entrant, like Wolff-Parkinson-White syndrome and supraventricular tachycardia. There is AV nodal re-entry, which calls SVT, SVT two types. Look, ventricular re-entry, give ventricular tachycardia, ventricular fibrillation, ventricular flutter, ventricular tachycardia. So this is the positions, how this is in a ventricle, this is a nodal, and this is the atrial, and this is infranodal. While automaticity, second main types, is the heart cell other than those of SA node, depolarize faster than SA node cell and take control as a cardiac pacemaker, overcome about SA node. What factors that enhance automaticities include increased sympathetic nervous system activity, decreased parasympathetic nervous system activities, and the vagatonic, increased carbon dioxide concentration, hypoxia, decreased oxygen concentration, increase in the pH, hydrogen ion concentrations, decrease in the pH acidity, and saturation in the chamber of the heart like left atrial enlargement, as we discussed in the mitral valve disease or in a cardiomyopathy. Hypokalemia, hypocalcemia, and other electrolytes is the most common. Example of ectopic automaticity is atrial tachycardia or multifocal tachycardia. Multifocal atrial tachycardia in patients with chronic lung disease or ventricular ectopy after myocardial infarction. While parasystole is really a benign type and rare, less than 3% of premature ventricular contractions, really as a localized problem, local small region of atrial or ventricular cell depolarizations. While the third most common mechanism is a triggered activity. This is after the re-entry or enhancement, automaticity enhancement or reductions. Trigger activity is like a domino effect where the arrhythmia is due to the preceding beat. So there is two types. Delay after depolarization, most common in digoxin, and the early after depolarization, most common in the hydroxychloroquine and quinidine. So delayed after depolarization arises during the resting phase of the last beat and may be the cause of digitalis-induced arrhythmias. Early after repolarization arises during the plateau phase or the repolarization phase of the last beat. May be the cause of torsade de poids, is a type of the polymorphic ventricular tachycardia. This is blamed to a lot of causes, one of prolonged QT interval, drugs like quinidines or the hydroxychloroquine. How to diagnose the arrhythmia? The test usually do resting ECG, Holter monitoring for 24 hours or 48 hours, events monitor, exercise-induced stress, loop, implantable electrophysiological study, echocardiogram, and coronary angiography. Arrhythmias recording by resting ECG, initial diagnostic test in all patients. But diagnostic if recorded during arrhythmia, and most of arrhythmia usually are intermittent, not so frequent to pick up by the resting ECG, and not recording in resting ECG, but initial diagnostic test is mandatory to do the ECGs. Resting ECG. Ambulatory 24-hour, 48-hour ECG indicated for frequent. What means frequent? At least once a day arrhythmia. Recorded every heartbeat during 24 hours period or 48-hour periods. Not helpful if arrhythmia is infrequent. The third is exercise. If indicated, arrhythmia provoked by exercise, so allow diagnosis exercise-related arrhythmia. It needs physician supervision. Event monitoring indicated for infrequent arrhythmia, which is every 1 to 2 minutes in duration. Small record is held to the chest when the symptoms are present, so the patient can fire this record and recorded the event, and sometimes transmitted it trans-telephone, what called trans-telephone recording, limited to the symptomatic arrhythmia. When the symptom develop and duration little bit more, 1-2 minutes, can record it. That persists longer enough for a patient to activate the device and recorded it. While loops recorders indicate for infrequent symptomatic brief arrhythmia, symptoms very brief, short period. It's not can be cut by the when recording and firing the record. So save the previous 30-second to minute signal, would save it, and the patient can't record, but the instrument and the loop recorder save it. So the patient activate the recorder. ECG lead this limit patient activities. While implanted recorder, this is to some invasive procedure with some risk, indicated for very infrequent arrhythmias, long continuous ECG monitoring. While electrophysiological study is invasive procedure with a complication, indicated not for diagnosis, it's for the treatment like catheter ablation or to know the origin and mechanism of arrhythmia and can be even test the different types or class of antiarrhythmic drugs. And it's an invasive procedure with some risk and complication because we put five leads during in the cath lab, one into the right atrium, one in the right ventricle, other in the AV node, the fourth in the bundle of his, and the fifth in the coronary sinus to see what happened in the left atrium, left ventricle. So what's the etiology? This is not mechanism etiology. It could be physiological and pathological. Pathological, a lot of causes. Valvular heart disease, ischemic heart disease, hypertensive heart disease, congenital heart disease, cardiomyopathy, as we study in the cardiomyopathy, carditis, myocarditis, pericarditis, right ventricular dysplasia, drug-related and pulmonary disease, and other causes. How the cardiac arrhythmia present? Presentation. Arrhythmia may cause no symptom, usually asymptomatic. The second most common is a palpitation, the patient feeling palpitation. Fainting, dizzy, spill, syncope may be presented. Chest pain, atypical usually, atypical chest pain. Heart failure, dizziness, as we said, palpitation. Second most common, fatigue, weakness. Tachycardia-induced cardiomyopathy, TIC, this type of the tachycardia, and even sometimes presented sudden cardiac death. We take some example, the sinus tachycardia. If we read the record and do the record, the rate we will find it 100 above to 160. P wave is sinus, QRS normal duration configuration, conduction normal, rhythm regular or little bit slightly regular. The clinical significance of this dysarrhythmia depends on underlying cause. It may be normal. Underlying cause, increased circulating catecholamine, congestive heart failure, hypoxia, pulmonary embolism, thyrotoxicosis, increase in body temperature for every degree centigrade, increase the pulse rate to the one about 10 beats per minute. Stress, response to the pain. Treatment include identification of underlying cause and correction. Look to this ECG, P wave QRS complex, P wave QRS complex. So it's sinus, but the rate is the more than and the 100, about 120 beats per minute. QRS complex normal, PR normal, shape and configuration. If we give a report, this is a sinus, really. But it's a normal sinus rhythm. But the tachycardia, the rate is more of what's called sinus but tachycardia. Sinus means from SA node and normal conductive pathway, but the rate is the rapid, so it's sinus tachycardia. Here the sinus bradycardia. The rate is 40 to 59 beats per minute, below 60. P wave is sinus, QRS complex normal, conduction, PR normal, slightly prolonged or slower rate, in a slower rate. Rhythm regular or slightly irregular. This rhythm often seen in a normal variation in athletic patient during sleep or response to the vagal maneuver. If the bradycardia becomes slower than SA node pacemaker, a junctional rhythm may occur. That the SA node, the bradycardia becomes slower than SA nodes, so the junction, and we'll discuss its injection rhythm may occur. Treatment include treat underlying cause, atropine, isoprenaline, artificial pacing if patient hemodynamically unstable. Look to this, about 30 beats per minute, 30-35, P wave QRS complex, normal P wave, normal PR interval is the regular equidistance between R waves, so it is sinus, but the rate below 60, so it's sinus bradycardia. Once the sinus arrhythmia is a change in a rate of the heart during inspiration, exhalation, and inspiration, inhalation. So the rate between 45 or 100. So within normal, but here is bradycardia. P wave sinus, QRS normal, conduction normal, regularly irregular. So there is irregularity, but it's coming in a regular fashion. The rate usually increases with an inspiration and exhalation and decrease with inspiration, inhalation. This rhythm is most commonly seen with the respiration due to the fluctuation in a vagal tone. The non-respiratory form is present in a diseased heart and sometimes confused with the sinus arrest, also non-sinus pause. Treatment is not usually required unless symptomatic bradycardia is present. This is the other, so it is slow pulse, this is a rapid. This is rapid, this is slow. So it is regular irregularity. This irregular, but it's regular, coming into two and then two in one. And this is the slower and this is the rapid. This is what called sinus arrhythmia. Most common cause of irregular pulse is sinus arrhythmia. The second cause is that the atrial ventricular ectopic, ventricular ectopic, and the atrial fibrillation. The most common cause of irregularities is atrial premature contraction, ventricular premature contraction, and atrial fibrillation. See you soon in the next lecture. Thank you for participation.